Welcome to the first public webinar of the Lancet Citizens Commission on Reimagining India's Health System. Thank you for joining us today. My name is Vikram Patel and I serve as one of the four co-chairs of the Commission. The Commission is an ambitious cross-sectoral endeavor that aims to lay out a citizens' roadmap for achieving universal health coverage for the people of India. And we aim to do this through the active engagement of diverse stakeholders representing both the actors in the health sector and the community. Please visit our website, the address of which you can find in the chat box, www.citizenshealth.in, for more information, but also to get involved. The Commissioner's webinar series is intended to serve as a platform for public health discourse in India and to engage a wide community of academics, practitioners, and the public on substantive and timely issues regarding health. The webinars will be held on the second Thursdays of every month going forwards, and you can sign up to receive alerts for future webinars and events through our website. Today's webinar, The COVID Crisis in India, What is the Way Forward, is the first of these webinar series. And of course, it is a critically important and timely discussion on what we consider are the priority actions for India to deal with the devastating pandemic surge and the humanitarian crisis it has spawned. We want to focus on the immediate actions that are needed to save lives and to stop the spread of the pandemic. We're hosting this webinar in collaboration with the India Task Force of the Lancet COVID-19 Commission. This is another Lancet Commission, an interdisciplinary initiative across the health sciences, business, finance, and public policy. And the India Task Force is the only country-specific task force set up in recognition of the unique challenges that India faces in the context of COVID-19. There will be a short survey which you'll be able to find in the chat box as a link after the initial remarks of the panelists. I encourage you all to fill it out, to share your thoughts and suggestions, both about the topic that we're discussing today, but also about topics for future webinars that you'd like to see. In order to address the rampant misinformation and confusion about the management of COVID-19 patients, most of whom can be kept away from hospitals with appropriate evidence-based treatment, I want to take this opportunity to alert you about an imminent new initiative that will be announced in the days ahead. A team of practicing clinicians from community-based and private organizations in India have joined hands with clinicians from several US universities to form a community science alliance committed to advancing scientifically sound evidence-based strategies for caring for our most vulnerable people. Announcements will be forthcoming on the Lancet Commission website. And now I would like to introduce Sarah Jacob, who will moderate our discussion today. Sarah Jacob is a journalist of repute and a senior editor at NDTV 24/7. She is the anchor of We the People, one of NDTV's flagship primetime shows, and previously she served as the US correspondent for NDTV, covering both the 2008 and 2012 elections. Sarah, thank you very much for accepting our invitation to moderate today's webinar. Over to you now.
Thank you so much. Thank you, Vikram. Thank you, everyone. India's indeed crisis in this current wave of COVID-19 infections. We're reporting 4 lakh cases, 4,000 deaths. Hospitals, daily hospitals and morgues are overflowing. Medical staff is exhausted. We have a shortage of oxygen. We have a shortage of drugs. We need to fix accountability, but we also first need to find a way out of this quagmire that we're in at this moment. So we're here this evening to look at the way forward, to focus on the short and the long-term actions that are needed, the lessons that need to be learned, the next steps that need to be taken to best suppress the epidemic in India. So thank you. The Lancet Citizens Commission and the Mittal Institute has put together leading experts from the medical and scientific and public policy community. I'm going to try and introduce them. Given their many accomplishments and the time limit that we have for this session, I'm sure I'm not going to be doing this much justice, but let me give it a shot. pull this up here. Okay, so of course we have Gagandeep Kang, one of India's most distinguished scientists, fellow of the Royal Society of London, the first Indian woman to be an FRS, one of the co-chairs of the Lancet Citizens Commission, a professor of microbiology department at the Department of Gastrointestinal Sciences at CMS in Vellore. Her work has been crucial to the development of India's Rotovac vaccine, a vaccine which, would you believe it, is both indigenous and affordable. She is a member of several advisory committees for the WHO, mainly related to research and use of vaccines. She's been since 2020 an ex-official member of the working group on COVID-19 vaccines established by the Strategic Advisory Group of Experts at the WHO. And of course, most recently, part of that 12-member national task force set up by the Supreme Court to find ways of tackling India's medical oxygen problem. So truly in the hot seat right now. We have also Dr. K. Srinath Reddy, who, in addition to, of course, being a very distinguished cardiologist, is possibly India's best-known public health expert, a pioneering institution builder in this area, president of the Public Health Foundation of India, a commissioner in the Lancet Citizens Commission, a member of the India Task Force of the Lancet COVID-19 Commission. He's formerly headed the Department of Cardiology at AIIMS, holds several advisory positions, several national and international bodies. He serves as an adjunct professor of epidemiology at Harvard. He's been appointed in 2017 advisor on health to the government of Odisha, rank of cabinet minister in 2020, same to the government of Andhra Pradesh, also with the rank of cabinet minister. Piatt joins us from London, England, I think. Peter is the director of the London School of Hygiene and Tropical Medicine College, a Handa Professor of Global Health. He is a special advisor to the president of the European Commission on Research and Innovation for COVID-19. Of course, one of the world's most highly regarded virologists. He's best known for having co-discovered the Ebola virus in Zaire. Professor Piatt is part of the team that isolated the Ebola virus in Zaire in 1976. He's led pioneering research in HIV/AIDS, women's health, infectious diseases, mainly in Africa. He's been founding executive director of UNAIDS, the Under Secretary General of the United Nations. And of course, he's been a victim of, most recently, of a moderate to severe case of COVID. And he's used his own experience with the illness, with the health system, in conjunction with his academic expertise to inform public discussion on this subject. So we'd love to hear from him on the experience in the UK and how we could compare that with India. We have K. Sujata Rao, a former Union Secretary of the Ministry of Health and Family Welfare, Government of India, the Commissioner of the Lancet Citizens Commission. She's been involved during her tenure in the first ever national program for non-communicable diseases, a process for a national policy for the use of antibiotics, introducing vaccines in public health. She's currently a co-chairperson of the High-Level Expert Committee on Health Reform in Andhra Pradesh, member of the National Health Systems Resource Center. She's worked in various national and international organizations during her career, including being a member of the Global Advisory Panel of the Bill and Melinda Gates Foundation, and also, of course, founding member of the Public Health Foundation of India. And we have Gautam Menon, professor of physics and biology at the Ashoka University, prior to which he was a professor at theoretical physics and computational biology groups at the Institute of Mathematical Sciences, Chennai. I told you the accomplishments are just numerous. They go on and on. He was founding dean of the computational biology group. He's currently adjunct professor in the Department of Biological Sciences at the Tata Institute of Fundamental Research in Mumbai. He works on a number of biophysical problems in the field of mechanobiology and the modeling of infectious diseases. Its implications for public policy has been a long-standing interest of his. So that said, I am going to now start by requesting each of our speakers to present their views on the immediate strategies needed to save lives in India and how we can minimize the pandemic's impact on the vulnerable in India, especially. If you could all speak for about 5 minutes each, that would be great. Dr. Kang, maybe you can start, because I happen to be speaking to an economist and policy planner about my moderating this event earlier, and he described you as also being fearless in expressing your views and of having no political leanings. So if you could set the stage, Dr. Khan, what are the lessons that India needs to learn? What should our next steps be?
I think when we think about the rest of the world and how it views India and how we view ourselves, we don't have a sense of scale. Perhaps, maybe Ms. Rao and Srinath Reddy have some understanding of this, but I always find that I'm discovering constantly all the parts that are missing in India's healthcare system. And that's why being part of this commission is very important to me. There are so many neglected people, neglected sections of the population that we never hear about. And while I might have understood migrant labor because I work with communities, I don't think I understood the scale of it. And I've only had 40 years in the healthcare system in the country so far. That was what was brought home to me more and more clearly through last year. So I think having a good sense of what we want to measure, in whom and where is very important. And then building the platforms to be able to provide access to care is important. I don't think we need, and it's becoming clearer and clearer, we don't need an AIIMS in every state or an AIIMS in every district, which is something that the government has been very focused on. But if we can build our strengths from the ground up, it will stand us in good stead in peacetime as well as in war. What has happened in this particular situation is over-centralization, a lack of recognition of the skills that are available on the ground, and that early command and control has now persisted for well over a year and is still to a large extent hampering our efforts to be able to deliver care to people that need it. I think the example of oxygen is just one among the failures we've had in that direction. There's a lot to do, but if we don't learn from this pandemic, we are never going to learn. I'll stop there.
So lack of centralization, more decentralization, really. Dr. Reddy, as India is struggling to contain its second wave, we have these fresh variants, double mutant strain classified as this variant of interest in India, a new triple variant. We're hearing all of this. This is creating fresh panic right now. So it seems like it never ends. What do we need to do to overcome this right now?
Well, let me start off by echoing what Dr. Kang has so very crisply stated, that what we really require is data-driven, decentralized decision-making. We do need coordinated countrywide containment strategy in order to bring down the transmission rates as quickly as possible, even as we are accelerating our vaccination programs. But since you asked me about the variants, let me start with the variants. Obviously, the variants are emerging because of multiple reasons, whether they've entered India from abroad or whether they've arisen here. The only way they can actually make an entry into the human body is through the nose, the mouth, and the eyes. So if we can get people to mask properly outdoors and particularly indoors, where aerosol formation can be fairly common and their double masking might be required. But most importantly, prevent sizable gatherings of people, particularly in static crowds. And super spreader events ought to be prevented as strongly as possible. Now, the question of immediate task, whether it's going to be a countrywide lockdown or a combination of lockdown and near lockdown in some states, that is a decision that has to be taken, of course, based on the assessment of the condition in each of these places. And sometimes it may have to be differentiated between states and even within states between districts. And that's why I'm pleading for decentralized decision making, but with a common template of action for decentralization. And we recognize, despite all the anxieties that are displayed by international observers, many of whom wish us well, like Dr. Fauci, who says that all of India must go into a complete lockdown. Well, you can't wrap all of India into one blanket. It's a huge subcontinent with a lot of variations across the country. And we do need to take firm steps, but they need to be somewhat differentiated based on the ground realities. Then, of course, we are really talking about early detection of cases, and that requires a good household surveillance of primary healthcare teams where available, but at least citizen volunteers based on not just testing, which is important, but on symptoms, history of contact and travel, and then referral for early testing of both the people who are suspected as well as the people who are contacted. Those are important elements. And there, I believe a lot of citizen engagement is required at the front lines. Then, of course, isolation and quarantine is required. But we must also recognize that for hospital referral, treatment, or even isolation at home, diagnostic testing, while it's extremely important, and it's important for a variety of reasons, including the fact that you still want to find out what the genomic testing will reveal about the variants and so on, as a follow-up of the actual initial diagnostic testing. But we must drive home the message that we still will have a number of false negative cases. And therefore, to depend only on the diagnostic test, either for the home isolation or for particularly for hospital entry, which has been unfortunately the bane of our hospitalization policy till almost yesterday. I think we must remove that aberration from our policy. Then in terms of home care, we need a lot more people to be provided home care with adequate support, both from primary healthcare teams as well as citizen groups that will provide the support. And then they must also be provided the assurance that they will have a emergency transport to a hospital where they are likely to get admitted with, again, a high level of assurance without having to wander from pillar to post. These are systems that may be put in place locally through a lot of local partnerships, and citizen partnership, which has been the missing element of our pandemic response so far, has to be brought in very, very strongly. We need people-partnered public health. So then the next, of course, we need to improve our hospital facilities, including temporary facilities. The oxygen crisis has to be solved. We have to provide oxygen security. We have to ensure that the drugs are appropriately prescribed, not have a mad rush for drugs which are really not required at a particular point in time. Like remdesivir is not even on the WHO list. Tocilizumab is misused in a number of people. So this is where clarity of scientific messaging and standardized protocols are also going to be required. As far as vaccines are concerned, I believe it's absolutely essential to ensure that every citizen who wants it and needs it gets the vaccine without having to brace the barrier of a financial hardship. It is a fundamental right, and that needs to be respected. How the center and the state will actually go about it and share the expenses is something that they can decide, but the availability of vaccine and access to it must not be left to the vagaries of a person's affordability or between a bidding war between the various states and the private hospitals. And of course, we do need to ensure that the support systems are adequately set up at every level. But I also believe that it is absolutely important that science must prevail at every level. Unfortunately, we have not been sufficiently respectful of science. Many of our decisions have not been driven by science. Of course, we have not been as bad as Mr. Trump's America, but we are certainly also falling short in some respects, and we must pay heed to science as we move along. So I do believe that if we take all of these into account, then we can emerge from the agony and anguish of this pandemic, and we can actually create a new health system which is much more comprehensive and compassionate. But before I end, I would like to say, it is not just these two commissions that are addressing this issue. I would strongly recommend that the viewers of this program visit the advisories issued by the National Human Rights Commission on the 4th of May, and again a few days later. While all of us may have forgotten that the Human Rights Commission existed for some time, these two advisories on COVID are remarkable in their clarity and direction and in detail. First one deals with what governments must do in order to ensure the rights with respect to COVID in a variety of ways. And the second one even talks about the rights of the dead. So these are remarkable documents, I believe people can actually visit and gain from. Thank you.
All right, thank you, Dr. So one size fits all doesn't work for a country like India of India's size and our nature, is really what you're saying. Peter Piatt, what are the lessons India can learn from the global experience? You live in the UK, which has just emerged from a harrowing second wave. What can India learn to emerge from this too?
Thank you, Sarah, and hello, everybody. Well, first of all, I think that we can all learn from each other. In this pandemic, I don't know of a single country that really knows it all in terms of a sustainable way. Even countries like, like New Zealand and so on, they're isolating themselves, but now they're stuck. For how long are you going to stay? So we all have to learn from each other. And I think that, only Indians in India can solve the problem in India. That's if only also because of the, as was said, the country is so vast. It's certainly one of the things I've learned. But I would say a few points. I look at it also, what can the world learn from India? First of all, that it tells us something about this epidemic and the pandemic. It is far from over. We've always hoped probably somewhere that, okay, there's the vaccines, there's the scientific breakthroughs, and that one fine day we will go back to normal. I think we should forget that term even and ban it. If we go to something, it will be going forward to the new normal, not going back to the old norm. And so it is, that's first point, it's not over. Secondly, I think that one of the big lessons is that this is kind of my English, my third language, my second language is French, and they said in catastrophe annoncée, it's an announced disaster. It was predicted. We've seen it also in Europe, all over, before in the UK and so on. So if you take the UK here, about a year ago, we were in a really bad shape. Was lack of leadership. The lockdown in the country was far too late when it was announced, and that you can estimate how many deaths that made. The health system was not prepared, and that ironically, there was countries were ranked in terms of preparedness for a pandemic. This was a theoretical ranking from the Global Pandemic Preparedness Coalition or something like that. And who came first? US. Who came second? UK. US going up to 1 million deaths. We have probably around 200,000. And the least one can say is that our predictors of, of whether you're prepared or not are not very good. And we were not really good. And so I was hospitalized in March, in the very early days. And that's why I have a high appreciation of oxygen and sensitive, and I can still feel very uneasy. I feel it in my guts when I see that lack of oxygen, which is so simple in theory, what a difference it can make. But what happened then is that there was a decline in infections all over Europe, of deaths and all that. But then, in a sense, we became very complacent. Very complacent. In Europe was driven by the desire to go on holidays in the summer, in our summer. And that's also very hard for democratically elected governments to control. And then we came with Christmas. And here, again, we were, relaxing the measures, the non-pharmaceutical interventions that were described by, Dr. Khan and Reddy, really were very relaxed. We had big parties all over, in the Brits before Christmas. It's everybody, big parties, getting drunk and so on. And this was kind of a real hotbed for transmission. And then in addition, there was a variant. Now, no virologist has been surprised that these mutations and variants pop up. I mean, that's what viruses do, some far more extreme like HIV than others. For politicians, it's very convenient to have variants because they can blame their own failures on the variants. But we didn't need the variant. It's a combination of this, early relaxation, premature declaring victory, and then making it the perfect storm with more transmissible viruses. So that's what happened here. Now, fortunately, I would say on the positive side here in the UK, the vaccination rollout has been really very good. Although in the meantime, the US has far more people who have been fully vaccinated than in the UK. The UK has gone for one shot and then we'll see who can get the next one. I got my first injection on the 9th of January, 1 year exactly after the sequence was announced, but that had nothing to do with it, no causal relationship. But then it took like 12 weeks before I got the second one. So, but that's going quite well. The rollout in the rest of Europe was slower, but now it's picking up. And I could say a few words about the EU because some of it is comparable to India. On the one hand, of course, the 27 members of the EU member states are sovereign countries. It's not like a state which are not fully sovereign. But the policies, we will have the same problem as Srinath said, because people live in country A, work in country B, they have a partner somewhere. If you close the shops in the Netherlands or the bars, people, they go to Belgium, etc., etc. So the fact that we didn't have a kind of coherent policy was a problem. But in terms of vaccine procurement, I think this was important. And the reason I'm saying that is that the option were that everybody for themselves, and the result would have been that the bigger countries like France and Germany and so on, they would have had the vaccines, but smaller countries, they could have waited. So this is where vaccine equity and making sure that everybody has access is really important. Now, so that's what the scale is. Now, I think that for India, the way I see it is that I agree with everything that was said before, and it has to be science-based, definitely, informed, using the formidable power of Indian manufacturing and so on, which is there. And what the international community can do, I always, it makes me a bit cynical when I see a plane is sending 100 canisters of oxygen or India, fine. I mean, that's not going to make the difference. What could make the difference is lifting export bans on ingredients to make vaccines and the commodities and so on. That is really the kind of structural interventions that could work. And there are no silver bullets here. I think that's really a lesson. You need this combination of what we heard all together. But I would also say, I always think in the middle of a crisis, we always need to think of never miss a crisis in terms of strengthening the systems, because there will be others. There will be, other pandemics, and this one is not over. So I would say that we're all very, very worried that this could be kind of a window on what could happen elsewhere also, be it in Africa, in the Middle East, in Latin America. Brazil is going along the same path with similar ingredients in terms of leadership, in terms of denial, relaxation, etc. So this is, of course, in the first place, a problem and a tragedy for Indians, but it's something that will affect the whole world, partly also, and because we depend on Indian manufacturing of vaccines for the rest of the world. And I understand it that, the vaccines are needed in India, but that's something that when thinking of epidemics, I had, had underestimated the importance of this. Yeah, you can call it vaccine nationalism, but I understand that the democratically elected leader wants to take care of their citizens in the first place. But what does that mean for the world? And one of the lessons is that we need also national or regional security in terms of manufacturing. And that's one of the reasons that, I think India can provide a lot of support for manufacturing in Africa, for example, or in other parts of the world. So but the top priority is now to stop this transmission and make sure that people don't die. And I think that there's a lot of sympathy, but again, no silver bullet, and it has to be solved from within India, from the various parts of India. That is clear. And thanks for inviting me. Thank you.
Top priority is to stop the transmission of the virus. I think everybody will agree on that as being the immediate first step. Sujata Rao, the second wave may reach its peak soon. It may start abating. There's no guarantee, though, that there won't be a third wave, as Peter points out, as we saw in the Spanish flu, as we've seen in America, in Europe. What would you expect? What do you think our government needs to do on a priority basis right now to get us through this?
Thank you, Sarah. I would just like to say as an opening sentence that, whenever we write about health, like Dr. Srinath Reddy will agree with me, we always start with a sentence that India's health system is in the ICU. India's health system is broken. India's health system is a battered one. Largely because for the last 7 decades, we have never spent more than 1% of our GDP. And so today, when we see so much of tragedy that is, getting more and more visible, it is really no one's fault. It is just that the system was not geared up ever to be able to take what is happening today. That said, I also think the wave 2 has been unforgiving in its velocity and in its fierceness. Because even if I assume we had a reasonably good health system, we'd still have not been able to cope with what is happening today. Now, my worry, to answer your question, what I'm most worried, and I think what government should do tomorrow morning, is to take care of the northern states. The wave 2 came in a big way in Bombay, which engaged all our attention. And as we've seen, Maharashtra has the capability, the institutional capacity, to really be able to contain, no matter how huge the problem be, and bring it down. Now, today, the positivity rate has come down to less than 10%. I think it's about 6%. It's a remarkable feat. And the epidemic has now, the virus has now gone to Karnataka, and it is going to the southern states, Kerala, and so on. But I'm not still so worried about it, because these are states which have huge number of doctors, infrastructure, and they can cope with it. They can do it. What is worrying me is the silent spread of this virus into Bihar rural areas, in the rural areas of UP, Uttarakhand. Uttarakhand has never had more than 8 people die. The last figure was 180 people dying in a day. And then you have Chhattisgarh, where 94% have been affected. I mean, you can go on with the Goa has about 50%. Every second person is infected in Goa. These are all not areas that we saw affected in under wave 1. And we really never, this was another, I think, missed opportunity, that we never really took advanced care to see that these virgin areas, which are not so badly affected in wave 1, would be the prime areas where the virus would find its home now. And that's what's happening. And in rural areas of UP and Bihar, the reports I've been getting through my own contacts for the last 2 weeks has been that there's just no, in Eastern UP, there are no testing kits. So people have been, today we see so many deaths coming out. It's largely because those with symptoms go to the center says, here, take a paracetamol, don't come back because we don't have the testing kits. They don't have transportation to take them to the district hospital. And so either they just die or they treat themselves well. So what is the situation today is we just need to open up and allow civil society and NGO partners and the local bodies to take charge in setting up isolation centers at these villages, where the people, with a rapid RAT, they can test out who are positive, get them isolated from the families, take care of them. If they're getting fever or something, whatever the home treatment protocol is, to provide that, use the oximeter every day. They're trained functionally in several of these NGOs that I know, and allow them to work. And if they get more serious, then of course they can be sent to the district hospital by having tie-ups. And some NGOs and civil society are doing very quietly a lot of good work, but they need to be strengthened, and they need to be encouraged, and they need to be allowed to participate. I'm afraid policy here has to be much more stronger in inviting the NGOs back, because this government has not been very supportive, though we hear the Prime Minister twice made a statement saying, please come forward and help. So there has to be massive decentralization to the local level, and that has to be, of course, done advisedly, because it's not as if the center can abdicate its entire responsibility to states and to the local bodies. It has a role to play. It has a function to discharge, responsibilities to discharge. And what do I mean by that is to really mount a nationwide campaign on promoting the use of masks. I don't think distancing, or I don't think washing hands is a recommendation that majority of our people can really implement. But the government can certainly come down heavily on any crowd gathering, aggregating centers, and simply not allow crowding, and also promote the use of masks. I think that's a huge IC campaign that we have launched before for family planning. We launched before for polio and immunization. We launched before for in a conservative society like ours, use of condoms for stopping the HIV getting transmitted. It was very difficult. We have launched before to give dignity to MSMs. In a highly conservative society like ours, it's not easy to promote respectful behavior towards men having sex with men. All this capability, this history, this knowledge is very much with us. And this needs to be tapped and used for doing a massive information campaign. And linked to that is the complete lack of rational treatment and accessible protocols. I mean, all we do is in TV shows, random lot of doctors come, and one is talking about remdesivir, somebody is talking about CT scan should be done, somebody says you shouldn't do it. I mean, why should there be this confusion, and people then take up whatever suits them and start self-medicating or demanding from the doctors for that kind of treatment to be given? I think very strong treatment protocols need to be drafted very quickly tomorrow afternoon for home care, for hospital mild and medium cases and severe cases, and widely publicized with retired doctors doing on telemedicine treatment of our doctors at the PHCs and the different levels, so that they know exactly what they should do, and not keep running around buying these extremely expensive, useless drugs for huge amounts and getting themselves impoverished. I have personally faced that in my own family, that even though Dr. Reddy said remdesivir is useless, I told them, but they still spent 2 lakhs and bought those shots, Finally, I have the most important thing that needs to be done again very quickly is a vaccination policy. That's something that has been engaging my attention. I think we have messed it up, and we need to straighten it out, because it is not anymore the question of the advisability of having differential pricing or the advisability of narrowing the eligibility criteria. That is there. But what is most important is improving the supply of the vaccine. There is no vaccine. And that is not getting the attention that it should. We are still hopefully depending on these 2 companies, which are producing today, as I talk to you, 61 million doses a month to take care of our demand of 1.3 billion doses to be done as quickly as possible to get that herd immunity that is so critical for controlling the pandemic. So this is not going to happen with these 2 companies. There are solutions. The state, the central government has got adequate powers. It is empowered to take very positive and solid decisions to resolve this problem. And I do hope that they do it very quickly and sort it out. Another 3 important issues which often doesn't get media attention or attention in public discourse is what's happening to the children who haven't been to school for the last over 1 year. They have lost their whole academic, they're children who learn every single minute. And here are children who are just cooped up at home and not going to schools. What about the children who both the parents have been taken off to the hospital because of COVID? Who takes care of them? So, I'm a member of this NHRC in Delhi. And so I was asking no, a member means there's some committee there. And they said they've identified about 1,200 children in Delhi, and they're trying to make child homes so that they can stay there till the parents come back from the hospital, of course, hopefully alive. So, this is a huge social problem that's emerging again. And I don't think we are really engaging with that kind of situation, which requires really immediate attention. And then the nutrition support. Of course, the Prime Minister has sanctioned some food grains and so on. But I think the midday meals have stopped, the ICDS nutrition programs for the little infants have stopped. Some places they're giving dry rations, some places that's not being implemented. That needs to be devised. And I have been a bureaucrat for 36 years, Sarah, and I have still, you can criticize it and you can critique it till cows comes to, birth comes to roost. But the point is, there is a capacity and capability for them to devise policies to address some sort of issues, provided they are allowed to and there is some amount of political support. And finally, of course, in the long term, I do think this is an opportunity we should not miss to bring in institutional innovations. The Ministry of Health, as it is designed today, is not going to be able to help us overcome the future pandemics at all. And there are going to be many more. If you see the history of this virus, starting with SARS in 2003, just see how many we've had over the last 10 years. And we never listened to the signals it was sending. There's SARS, there's Ebola, there was MERS, there was H1N1, there's swine flu, and it went on and on and on. And now finally it's broken up in this very dramatic, traumatic manner. And we have sat up and noticed it. And I don't think we're seeing the end of it. So I think there has to be, after we have quietened down and the fire is put out, what we're going to see a wreckage everywhere among all sections of our society. And I think we'll have to have these battered lives have to be rebuilt again and systematically. And I would say that we should probably gun for a council of sorts with the Prime Minister chairing it, with the chief ministers, to sit down and slice out which are those population segments that require special interventions to get them back to the old normal as we knew before the pandemic. Lost incomes, lost educational opportunities, lost parents gone, lost families, and so on and so forth. So I think that's something that we need to do. And finally, of course, systematically rebuild our health system. Even as I said, let me come back to my loop. Bihar has, the average for one doctor for population in India is 1,500. Bihar, it's something like 1:27,000. How do you expect anyone to do anything? So there has to be a massive attention to UP and Bihar in terms of just not the hospitals and oxygen plants, but the human resources. And even as I'm talking today, it's very important for them to take innovative actions, which Prime Minister said will get the fifth-year MBBS students to work, whether it's fifth-year MBBS students, Ayush practitioners. I've been extensively in UP. Some of them are really good. So some of these very experienced Ayush practitioners, after all, giving an injection and giving paracetamol doesn't require you to be a great shot specialist. And refer when you see the oxygen falling below 88 and take them to the hospital. So these kind of nurses and so on, we have to ramp up and provide more doctors and human resources personnel support to both these states to cope with what's really coming out. It's a very grim and a serious situation, and I think they're doing their best in Delhi. I can't think of saying that nobody's scared or nobody's doing their work. But the point here is that a multi-faceted approach may have to be taken, and very quick decision making on some of the 2-3 important issues that will make a difference. Because I would like to end here. Why I'm saying vaccine again, whatever you take decision today, it will take 3 months for you to get the kind of required vaccine. And I am saying that instead of 61 million, we have to build a capacity to get 300 million doses a month. Instead of vaccinating 4 million people a day, we have to reach up to 10 million persons in the back. And now, do you say that is it a realistic target? I'm putting my entire 36 years experience on a wager to say we can do it. But provided there are lots of caveats in it, all those policies are taken care of. So let's hope that we come out of this very quickly. It's been a traumatic experience. Many of us have lost our friends. Many of us have lost family members. We have lost, still have good friends battling for their life. So it's very difficult to talk about wave 2 without getting emotional. So let's hope that we just get out of it fast.
Thank you, Sujatha, for that. Really giving us a comprehensive look at what the problem is. Let's hope we get out of this. Will we get out of this, Gautam Menon? Modeling infectious diseases is something you're been interested in for a long time. Any good news at all on this front? When do you see this wave peaking? Is the third wave inevitable? And if so, what do we need or what can we do to prevent one?
Thanks, Sarah. Let me just start with a sort of broader issue before we can even discuss a problem like that. And that's the question of data and its absence. And how do you make a transition between the anecdotes that you hear to real evidence on which you can base some sort of policy? And the questions that you raised about what happens in the future are, of course, questions that are important because they are the difference between a purely reactive policy versus something that is proactive, that tries to anticipate what might happen in the future, even though you can see it only somewhat imperfectly. So that's why you need models. But right now, as Sujatha Rao pointed out, models have to deal with a whole lot of very corrupted data at the moment. And right now, the numbers that are coming out of states such as UP, Bihar, Jharkhand, etc., it's not clear to what level one can trust these numbers anymore because of the huge variance that you see between actual on-the-ground reports about deaths and cases, etc., and the numbers that are reported officially. So along with that is all of these new entities that have entered the description, the new variants, the B1617 variant and its various sublineages, some of which may be more important than the other. So models have to now retool and readjust to account for a whole lot of more complication than the original models actually used to do. So I just want to talk about what goes into these models, the nature of data, and where to get the information that feeds into these models in the first place. Much of modeling really now continues to use numbers that are derived from either Western, US, typically US, UK data, or Chinese data. There's relatively little that is based on completely Indian data because we don't understand those numbers in a comprehensive enough sense. So one thing that we do know is that as you get to the older populations in India, to the 65 plus, their levels of mortality in that age group is a little less, is somewhat less than the analogous numbers for the Western population. So that's certainly work that we do know. That's a one sort of solid bit of evidence that we can peg any sort of analysis on. But much of the rest really we don't know. For example, anecdotally, it's supposed to be that in the first wave, there were a very large number of asymptomatics. But is that number 50%? Is it 80%? Is it 90%? You'll hear a huge range of numbers. And we don't have anything that really enables us to pin a specific modeling parameter on that. What about the symptomatology in the different waves? Are people showing different sets of symptoms this time? Not very clear. Again, we just have anecdotes and no real information. But the real interesting point that I want to make is just the answer to this question. By the 15th of January or the 15th of February, let's say, when the second wave took off, how many people in India were infected through the first wave? It looks as though that's a straightforward question to answer. I mean, in a sense, it's the most basic question. You had a peak that went up. It peaked around the 15th of September. It came down very gradually. There was a little blip during the festival season in India. But by and large, it really came down to levels of a little above 10,000, let's say, by about the middle of January, the end of January. But the question of how many people were infected, you get answers all the way ranging from about 20% at its lowest level to something like 60 to 70% at its highest level. The only large-scale information that we have comes from the ICMR serosurveys, which give you numbers that are really on the lower end of the most conservative estimates that you have, because they tell you it's somewhere around 20 to 22% pan-India, with that number being larger in the cities. But if you look at the serosurveys in the cities, you get much larger numbers. You get numbers like 50%, 60%. So one thing that's obvious is there is some gradient between rural India and urban India, and it's important to account for this in the calculations. But it's interesting that there is no theoretical calculation really that gets you a number that is low, that is that low. This has very important implications for the number of people who are susceptible to the second wave. How many people are left at the end of the first wave who could catch the disease if you assume that reinfections are not important? So that brings me to the second point about numbers. What is the importance of reinfections? How many people are being reinfected? People who were infected the first time and now catch this infection again. Does having it in the past, does it protect you in any way? Are we talking about 5% of the people who caught it the last time catching it again this time? Are we talking about 20% or 30% of the people who caught it the last time catching it again at this time? This is a number that we don't know at all. The other problem, of course, is vaccine breakthroughs. Anecdotally, all of us know of people who've had 1 dose of vaccine, 2 doses of vaccine, etc., and then caught COVID-19. As far as we know, it's very protective. Any vaccination is protective against serious illness, but certainly there are people with some level of mild symptoms or those who test positive. And then the question is, there has been some level of breakthrough there. Can we estimate the fraction of people with, let's say, mild symptoms or possibly even severe symptoms among those who've been vaccinated? We have no good numbers there. We just have anecdotes at this point. So where does this information come and how does one lay one's hand on it? Well, first of all, I said you can just go by anecdote. You can go to a specific hospital or a specific small state and try to get this information. But this information is actually all there. The Indian Council of Medical Research, the ICMR, collects information about every test that has possibly been done for COVID-19 in India, every test, okay? So with that information, given that it's linked to Aadhaar numbers, to various IDs, to telephone numbers, etc., you can ask if someone tested positive in March or April of last year, did they test positive again in October of last year? Of the people who tested positive in October, how many of them are testing positive again in March or April at the time of the second wave? That's important information. You know what tests they took. Are the tests, what is the accuracy of those tests? Can you assess that from that particular piece of information? Can you link databases together? There's an agency that looks, for example, at vaccines. Can you link records of people who've been vaccinated to records of people who test positive and combine that particular piece of information together? Can you look at Arogya Setu data, which monitors how people travel, for example, once they download that app, and ask, did this expansion of people's movements, did that have any correlation to how the disease spread? You can look at the databases set up by the INSACOG, which is genomic sequencing set up by the government. And then you can ask, where are these new variants coming from? Was there any early warning signal in those variants, in the data, in terms of a sudden rise in positivity of cases that were done at the district or the sub-district level? The point I want to make is that this data is all there. It just has to be released and made available, appropriately anonymized, to people who can study it. Right now, that database is just increasing in size. If you look at the number of tests, it's a horrendous number of tests that we've actually done. But the analysis that has got to go in to extract every little piece of information that is of incredible relevance to the way we understand COVID going forward, that analysis is not being done. So I think for me, it's a priority when I talk of data, when I talk of models, to ensure that we have sensible material, sensible information that feeds into those models in the first place so that we can make some level of progress. Let me just finish. I mean, everyone who spoke before me said all the right things about masking, about improvements of the health system, etc. Let me just make 2 points. One is that we know that this disease came from a spillover event, came from bats into human beings, so possibly through some intermediate animal. The whole field of disease ecology is a scientific field that tries to look at these relationships between veterinary health, animal health, forest deforestation, human encroachment, etc. This is an important field from a scientific point of view to thinking about what might happen in the future. The second point I want to make is a point about ventilation. We've heard a lot of discussion about masking and so on. We have not had enough discussion in this country about ventilation. We know now that ventilation is absolutely crucial to the way the disease is transmitted between people. We need to have discussions around how to retool or re-ventilate classrooms, public spaces, areas. We need to encourage people to go out. As I keep pointing out, our messaging has been consistently negative. It says, don't do this, don't do that, don't do something else. But the one positive that we know is that you're approximately 100 times less likely to catch COVID if you're outside and you're well masked in a not too crowded situation. In our messaging, let us try and emphasize these things, emphasize the role of masking, emphasize the role of ventilation, and think about these in concrete ways. And that's where science and technology and engineering, all of this information that we've gathered about the disease and how it spreads, that's how we can feed into sensible decisions. Thank you.
Okay, so simple steps, I think both you and Sujata Rao, simple steps that can have great outcomes, right? Just masking and ventilation. But you touched upon the importance of data. You have a minefield of data out there, but it needs to be studied. It needs to be understood in order to work to our advantage. Dr. Kang, to you first, a higher understanding of the scope of India's outbreak is crucial to controlling it. Is that why we're seeing mutations and variants? Why are we? And if we're going to continue to see these mutations and variants, are we then just playing a cat and mouse game with vaccines?
I think one thing that's really important to understand about this virus is that among RNA viruses, it evolves relatively slowly. But because there is so much around and it's replicating in so many different people, it's almost inevitable that if we allow it to continue to replicate like this, we are going to continue to see variants coming at us very fast. Remember, we didn't have a lot of variants early on. That was because the virus was in a population it had not encountered before. And then as it had time to multiply, as it's now starting to encounter people that are protected, it's starting to get into people who are immunodeficient. It has opportunities to change. And the only way that we can prevent variants or slow variants down is by slowing replication of the virus. Now, in India, where we obviously are underestimating the scale of infections. The serological surveys told us that, and the data that is in the news every day is telling us more of that. Just emphasizes that when we need control and we haven't found a way there yet. In this particular, over the last 3 or 4 days, the numbers have been a little bit less, but it's also been in the background of testing numbers changing a fair bit. So we can't consider that we are done yet. And as far as I can see, this is something that has affected the West and North and is spreading East and South. So there is much more to come. What I don't get is that we understand the principles for control, and we have been very reluctant to apply them, whether that is by all the methods that everybody has talked about, and thinking about how you slow spread through lockdowns or limited lockdowns as are happening now. Why can't we have a concerted effort to do this? I think it's back to what I mentioned previously. There is not an understanding of who is accountable for what. And as long as you don't have both accountability as well as responsibility, it becomes very difficult to deliver on the interventions that are required. So if we are to achieve any level of control to suppress virus replication, we need to do all of the non-pharmaceutical interventions and roll out vaccines at exactly the scale that Sujata mentioned. 10 million a day is achievable, but we have to be working together to do this, and we are not.
Talking about vaccines, Sujata Rao, you've emphasized the importance of vaccines. Everybody's talked about decentralizing. In a sense, perhaps some would say the center has decentralized a bit in the manner that they've asked states to now directly negotiate with vaccine producers in India and abroad. Is that a solution according to you? Is vaccine pricing something that states can do? You've been the health secretary. And at this stage, if you ask a state to go to an Indian vaccine producer or go abroad, wouldn't most people already have committed to orders placed by other countries earlier? Other countries who had the foresight to place those orders earlier?
I just think the way they're going about it, it's very bizarre. To begin with, we have had a very well set, working well program where the central government, it's a shared responsibility, infectious disease control in the concurrent list of the Constitution. So when central government says we have done this, they're not doing any state a favor. It's their job and it's their obligation to do that. So in this shared responsibility of infectious disease that cross state borders. The central government has always been responsible for procuring the vaccines only because it has a big market, and therefore its negotiating power is definitely much more. And two, it will also be able to get some kind of a uniformity in the type of vaccines that are being provided and used throughout the country. And for this reason, they have not only got the capability of issuing global tenders if required, negotiating, and also the most important, the quality assurance mechanisms are well honed in the central government. Now, suddenly the central government switches this whole policy and says to the states, you go to the market and buy your own vaccines. So are we going to have Jharkhand, having a Chinese vaccine, Bihar having a Sputnik, and having a different, Maharashtra having Pfizer? I mean, everyone's going abroad. I mean, how does it happen? Because any vaccine that comes from outside, it has to be approved by the drug controller, who comes under the administrative discipline of the central government. And so therefore, now they have waived bridging studies. I don't know what Dr. Khan feels, but do we allow any vaccine to just come into the country and be used anywhere without any understanding of what its implications could be for the people of India? So, there are so many issues involved that you can't have this mad situation where 20 vaccine companies are coming and each one is giving in part or full to different states. So that's not the way we implement this program. What we need to do to achieve the $300 million, 300 million doses, is to use our powers of compulsory licensing. That's a power given to us under the TRIPS agreement, precisely to face the kind of situations that we are finding ourselves in, precisely for this. Never has India ever been in a situation where we needed to think about compulsory licensing. This is the very first time. It's a national public health emergency. And what does it mean? It means that biotech, for example, the Covaxin, is completely indigenously produced. We don't need anyone's permission. You issue the compulsory licensing that should have been done way back in December or January 3rd, when emergency authorization to sell was given. You have the power thereby to fix the rate. And you have about, at least there are 10 companies, there are 4 in the public sector, another 3 or 4 more, which have the capability to manufacture this vaccine in the country. And so therefore you ramp up biotech and Bharat Biotech and Serum to produce what they have, about $200 million doses they can easily go up to, another 100 or 150 million through these other companies who are given the technology. And why I said the immediacy of decision making is important today. Today, if the government does take a decision on this issue, it will take a good 2 months for the technology to be given to these different companies. They have to revamp the production lines. Some assistance may have to be given to reach that production by July, August. And we have 300 million doses, and we do micro planning at the district level and below. And as I said, if we could vaccinate 26 million kids on top of the bus, inside the villages, across the river, sitting in the fields, in railway stations and so on, we can easily 10 million vaccinations in a day. It's not at all difficult. And so then we can achieve and think of having a herd immunity.
Short-term, long-term solutions, short-term masking, ventilation, focus on that, long-term, build up the infrastructure to have more vaccines 2 months, 3 months down the line. Dr. Reddy, I'm looking at my news feed, and the breaking news right now is that the gap between 2 doses of Covishield has been widened to 3 to 4 months based on a recommendation of a COVID working group. Of course, questions being raised about whether that's because there's a shortage of vaccine production. I think, am I wrong? Are you on this panel? But I think the larger question is there scientific evidence to support this? And if so, is that going to be made public?
I'm not on the panel, so let me clarify that straight away.
Okay.
Hello, can you see me?
Yeah, we do. Go ahead.
Okay, I'm not on the panel. Let me state what I understand is the state of science here. The AstraZeneca trial, conducted mainly in UK and some other countries, had two strands which were accidentally created of basically having two full doses of the vaccine given 4 weeks apart as per protocol, and an additional smaller strand which had half dose initially and a full dose second time. And some of these were spaced at 3 months in what was called a contractor's error. Nevertheless, they found that the dose that was given 3 months later with that particular dose spacing had better immunity demonstrated in terms of efficacy when the trials were completed. And the British regulator accepted that position, and so did the WHO, which said, okay, because it's showing greater efficacy, we will give it 8 to 12 weeks. That's what WHO said. But then later, a US trial with 32,000 patients, which was the larger trial, had 2 full doses at 4 weeks interval, and that showed 76% efficacy. So you can choose what you want from the various trial groups of AstraZeneca, which has been a bit messy, to say the least. But nevertheless, there is an option available up to 12 weeks. Beyond 12 weeks, we don't have a clear-cut proof. The WHO accepted 8 to 12 weeks. Spain is the only country which has gone up to 16 weeks. Now, based on the immunogenicity studies, some difference has been offered that if you do greater spacing, you're likely to get a better immune effect. But if you only go by the efficacy trial, then I don't think you should cross the 12-week boundary. Now, why they've gone up to 16 weeks in India? Is it to follow the Spanish example? Is it to give greater availability of doses to people for the first dose to be spread out to more people? Those are all possibilities. But the science is what the trials have stated.
All right. Gautam, this brings me then to the issue of transparency, a trust factor. You've touched upon this, trust in public institutions, effective, honest communication really at this point of time, transparency when it comes to reporting cases, mortality numbers, hospitalization, and all of this, as you've all pointed out, needs to be led by scientific evidence using data. If you could just, what needs to change going forward?
I think it's certainly a question of attitude more than anything else, that government agencies should be comfortable with providing material to the public that the public pays for it, right? Everybody pays taxes for it. And material that is collected, provided you properly anonymize, make sure that all security regarding the divulging personal details is left out of it. This is very important data. So it's important to be transparent. It's important to put in processes that check for transparency. The default should be transparency. You should have to make a special exception if you want to conceal something. As a number of people have pointed out, in particular the journalists, you should not have to file an RTI to get some information that is of this nature. It's crucial to a public health effort. It's crucial to understand where cases, deaths, etc. are going in the country. Where will you be 3 weeks from now? Where will you be 6 weeks from now? Not just for COVID-19, for everything. So let us move to a situation where the default is access. And to conceal is something that you have to make a special argument for.
Especially since the solution to this pandemic could lie in that data. Okay. All right, it's now 6:40, so I want to start taking some questions. Peter, someone has a question here that is what I wanted to ask you, because as you said, I think somewhere I was reading up and you said, like COVID-19, the virus disappears, but its consequences linger for weeks, as Sujata Rao also pointed out. So we have a question here from someone who's logged in. What are the repercussions of the global divide between the developed world and low-income countries with respect to COVID-19? How can this be addressed? Because perhaps depending on who gets the vaccine, you can see the world now divided along new lines between the haves and the have-nots.
Yeah, Sarah, really important question. I think it's one of the biggest geopolitical issues in addition to the issue for COVID itself. And the truth is that this problem, the pandemic, will not be over until it's over everywhere.
Yeah.
And so there is indeed a divide, and there is a moral issue here. There's a, when you have here in Europe and in the US, we talk about vaccine passports or certificates so that people can attend events, can travel and all that. And those where the vaccines are not available will not be able to benefit from this kind of new type of freedom. So that is one issue in terms of fairness. But secondly, what's really very important also is to go back to what Gandhi said about variance and so on. It's in the interest actually of every country, even the wealthiest country, that every single country in the world has full access to vaccines. Because as long as there are certainly millions of people living and with this virus, mutants will arrive and variants will emerge. And these variants then at some point may become really ugly. At the moment, it looks reasonably okay for certainly to prevent serious illness and death with the current vaccines, but nobody will be safe, no country, if the virus is circulating widely. So this is a really rational, a very strong argument for, let's use that old-fashioned word for solidarity, but for massive vaccine rollout. And that's where we were all very hopeful to India, because let's not forget that Indian companies produce over half of all vaccines in the world already in, let's say, in normal times. So it's going to be key that for the rest of the world that the epidemic is brought under control in India. That will be, of course, in the first place, benefit Indians, is going to benefit the whole world. So that's why international...
Critical for pandemic control itself.
Yeah. So that's why this international collaboration is so important. But as you said about, as we heard about India, even here in the UK, Scotland and Northern Ireland and Wales and England have different policies for entering the country. And we're only about 65 million people. So that doesn't make even a big state. So it's not that you have a unique problem. What you are unique in, of course, is the size, the vastness, and the fact that, you have a perfect storm of everything that was said. But we need a global solution for it. And there has been global failure. I mean, when I was, in working in AIDS, we had HIV discussed at the UN Security Council, at the heads of state level. I came many times to India, and Sujata, I was involved in it, for example, and also Srinath Reddy, a special session of the UN General Assembly. We haven't had any of that with COVID, and yet this is like the biggest crisis in peacetime that the world confronts. So there's been a real lack of the national leadership. That's why the leaders of every country, they have to connect and also particularly make sure there are no barriers erected against each other, because that is also, we're a lose-lose at the end of the day.
Absolutely. All right, from the global, we have a question, taking it down to the local. Sujata Rao, perhaps you can take this. What measures should be taken to prevent the spread of COVID-19 in villages? How might these strategies differ from those in urban areas?
Well, the strategy will differ in the sense that, you have to understand the fact that in many of the rural areas, and particularly, as I said, the northern states, they don't have access to health facilities, doctors and nurses. So much of it has to be within the community itself. So we just have to use the community resources. For example, Bihar has a very vibrant self-help group movement. So they are a very big, huge societal resource that needs to be utilized. And then we have the Ashas who are in every village. So there's a lot more time and energy has to be spent in trying to get informed people at the village level, and then help them to organize and isolate those who are infected and protect themselves from getting spreading infection in their communities. And that kind of effort has to be made, which also means providing that kind of money and stop elections. I know even as I'm talking now, in Bihar, they're getting ready for panchayat elections. Jesus Christ, I don't understand. I mean, with all that's going on, how can they be thinking of holding elections in the rural areas right now? So there has to be some understanding at the political level to say, let communities take charge. I want to give one example here. When Ebola struck Sierra Leone and Liberia and so on, US and
Sorry, we seem to be losing the line there with Sujata. Can the rest of you hear me? Okay, so let me try and just having another question that again, I'm also very
resources. So that is the critical point. We have not appreciated the importance of communities and civil societies and local panchayats. Kerala's whole success is largely because of that. As you know, the gram panchayats, which are so empowered, and they've been able to address the issues there itself.
So go local and decentralized. Another concern that everybody has right now, Dr. Kang, perhaps you can address this, is these reports that children are likely to be affected more in the third phase because as you've said over here, new mutations continue because the virus will reproduce whenever it finds a non-immune, unvaccinated body, and they will jump onto that next vulnerable person. And children are unvaccinated. We don't have a vaccine, certainly in India right now for kids. So is this a concern, and what do we need to do to protect our kids?
I've heard this third wave and children are going to be more affected story, and I don't understand it. Children have been affected in the first and second waves as well. Yes, we are going to vaccinate everyone down to the age of 18, which also I think is way too hurried a strategy. We don't know enough about the variants and whether this is really required to move this fast for the lower age groups. I would much rather focus on covering the older age groups first and then do an age descending strategy.
A shortage of vaccines.
I think the age descending strategy makes sense if we want to prevent mortality. I think taking doses away from the over 60-year-olds and giving them to people who might be more economically productive at 25 is not the way we should be going, because the risk is lower for the 25-year-olds. So with children as well, they will get infected, but their risk of severe disease is low. It's not like it is absent. There are certain rare inflammatory syndromes that are seen in children, but it is for sure something that we really need to think about very carefully. The third wave, I think there will be third and fourth and fifth waves because we are not going to vaccinate everybody. And there will be enough susceptible people in this country to continue to see smaller waves and outbreaks. They'll become maybe more localized. If seasonality plays a role, then we will have a better understanding of what that is once we've had the virus circulating for a couple of years. I think there's a lot to learn, but children and the third wave, no science that I understand.
I'm so glad to hear you say that, Dr. Khan. Thank you. I want to just, something that Dr. Mitchell Weiss from the Faculty of Global Health and Social Medicine at the Harvard Medical School has talked about. We haven't touched upon this enough. We did so in the beginning of the first wave, certainly in the media, but the impact of this pandemic on mental health. He spoke about the video coverage of cremations, non-specific reports of global shortages flagged by leaders in India. But overall, mental health is something that could be the next major pandemic for India. Anyone like to take that?
Vikram is around.
Dr. Reddy? Is something...
I can certainly take it up, but when you have Vikram Patel on the panel, I think it'll be inappropriate on my part to try and...
An issue that we seriously, we haven't given it much thought.
No, I entirely agree. I entirely agree.
The issue of mental
No,
health.
there are many issues now. It's not just after the pandemic. I mean, apart from what is happening to the person who is suffering, what is happening to the person who's having long COVID and brain fog, you're also seeing the impact on the family members. You're seeing the impact on even people who may be unrelated, looking at the visuals, and the whole experience of anxiety, fear, alienation. All of this is a tremendous drag on my mental tranquility and stability. And I think we do need, particularly when you're isolating people, and in the initial stages of the pandemic, we were dragging away people to isolation rooms and quarantine without even really explaining what is the kind of family contact they're going to have. So in a sense, we have even actually put up notices on people's houses. That kind of stigma also we have created. So I think mental health has been violated in very many ways, wittingly and unwittingly, and we ought to really pay attention to that. And then we do need to create that compassionate support. And again, this brings in the whole issue of community engagement. It is the people in the community who are closest to you. It is those networks that are likely to provide you the greatest support in these cases. Of course, professional help is also required, whether it is a family physician or a primary healthcare doctor or a nurse or the Anganwadi worker or the ASHA who is actually tending to you and most of the time in terms of the primary care, the self-help groups that Sujata talked about. All of these people are going to be important, but we do need to create conditions. And we have spoken of children. More than immediately the impact of the virus, it is the impact of mental health challenges that are created for children because of parental illness or seeing elders dying in the family or being isolated, shut off from their peers, and wondering about their education and employment future. These are things that we must take care of even now, even while planning for the future.
All right. Thank you all. Unfortunately, we've run out of time. So much more to talk about. But clearly, if I can just try and wrap up, no single response to defeat the COVID-19 pandemic. Decentralize, transparency in vaccine deployment, transparency in data. And of course, most importantly, we need to start investing in our health. A range of actions needed for effective response. We hope that, this conversation can provide some guidance to policymakers at the center and the state, how to move ahead to plan to overcome this current wave and future waves that, as you all are saying, are definitely coming. But thank you all. I want to just quickly pass on, hand over to Tarun Khanna and Kiran Majumdar-Shaw, both who are co-chairs of the Lancet Citizens Commission. And if you could give us the closing remarks right now.
Kiran, you want to go first?
Sure. I think I must thank the panelists for a very, very thoughtful discussion. I think we've actually deliberated on a number of very, very key points in terms of how do we deal and get through this second wave in India. And I really believe that some of the very important and pertinent points that came out were about the dependence on reliable data, the fact that we have a lot of valuable data that we need to use for modeling better, the fact that we should look at how we want to vaccinate, how we want to decentralize, and more than anything else, I think the fact that Peter also talked about is that India needs to find ways of solving its problems, because India is a very vast and diverse country. And, it is about, working out its own model, because it's not about one size fits all. Learnings are there, we can share learnings. And I think there were other important points made about how this particular pandemic has exposed the frailty of our healthcare system. Sujata Rao very, put it that, we need to make sure that we invest and continue to invest in strengthening our healthcare system, because that's what this pandemic has exposed, that we just are underinvested in healthcare. And I think we ought to use this pandemic to finally convince ourselves that investing in healthcare is the right thing to do because it's of compelling self-interest. We have to be prepared for another wave, even if I'm hoping that it will never happen. But I think one thing that this particular second wave has shown us is that we were not prepared. And I think the complacency that we all seem to have displayed, whether it is the UK over Christmas or whether it is India over recent, months of elections and other religious festivals, we have got ourselves into serious trouble. But I think I, for one, remain optimistic that we do have we do have the way forward. We are the vaccine producers of the world, and let's vaccinate our way out of this. I know that Gagandeep has talked about going through an age-tiered vaccination process, but I do believe that this time around we are seeing far too many young people dying. And that's what worries me because the mortality rates that we are seeing this time around are far greater amongst the younger people than it was in the first wave. Maybe it's because of the tsunami that has hit us. But having said that, we do need to work out good models like Gautam Menon talked about. We have this very rich reservoir of data. Let's use it intelligently and apply it for our greater good. So thank you, everyone. I think this has been an excellent webinar, and we will have more of these because it's very important to get citizens to really listen and exchange ideas and ask questions. And that's what this commission is all about. Thank you.
Thank you, Kiran. As usual, Kiran is far more eloquent than I could be, and essentially said everything I was going to say, so I won't belabor it. Let me just thank all the panelists and Sarah, of course, for kindly moderating this. And a number of people here are super busy, particularly in dealing with the pandemic, so we really deeply appreciate it. On behalf of my co-chairs of the Lancet Citizens Commission and the Mittal Institute at Harvard, thank you all for joining us. There is a survey link in the chat function. We'd be most grateful if you could fill that out so that we can serve you better. All the best.
Thank you.
Thank you. Thank you.
Thank you, everyone.
Bye, Sarah. Thank you.
Thank you so
Sarah.
much.
Well
Thank
done.
you.
And thank
Bye,
you,
everybody.
everybody.
Well,
Bye. Bye,
thank you,
everyone.
Sarah.
Bye.
Bye, Tara.
Thank you.